Hi, I'm Dr. David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist, and welcome to Two Shrinks and a Mic.
Today, we're going to continue to talk about some of the challenges that both the mental health professionals face as well as patients who come in for treatment. We've talked many times before about how our field is so different than other fields in healthcare, especially medicine. You know, if you have high blood pressure and you go to your internist or you go to an endocrinologist, generally speaking, the evaluation and treatments are going to be the same, whether you're in the state of California or the state of Florida. Their protocols are very, very similar. But in our field, there's a huge spectrum of treatments and a huge spectrum of evaluative techniques so that it's much more difficult to really clarify it. So today we thought we'd spend some time talking about how do you decide if you're seeing a psychotherapist when it's time to be on medication, and when do you decide if you're on medication, seeing a psychiatrist, that psychotherapy is involved, and how do the professionals make those decisions?
It's a tough one, and it's also different than general medicine because, in general, if you go to a doctor for whatever your illness is, and the doctor says, "Well, you need to take this medicine," there's very little resistance to it for the most part, or anxiety about it. Even if there's fear of the side effects of the medicine, there's generally a very high level of compliance. With our field, people have a resistance to taking medicine because they're afraid of it. They're not sure what it's going to make them feel like. And even if you reassure them that it's geared towards reducing or eliminating their symptoms, they still are afraid that maybe it'll change the way they are, that change their personality or things like that. So you're really up against a few forces. One, trying to decide if the person really needs medicine, and then two, dealing with the natural apprehension resistance about taking psychiatric medicine in general. It's a much bigger step for most people to take the medicines that we utilize compared to if you go to your primary care doctor or your ear doctor or something.
You know, we both of us will see individuals who have seen a number of other mental health professionals before and come to us because of either lack of adequate response or other reasons. And then we also see individuals who have never seen a mental health professional before for the first time. So the challenge for both of us, I think, in the beginning is to clarify the nature of the problem. You know, it's somebody who's come in fresh. My initial job is to be a good listener, ask the right questions, and get as much valuable data and objective data as possible to figure out whether this is a major psychiatric disorder that requires intensive treatment or whether this is a life situation that requires some transient psychotherapeutic treatment where talking about the situation and learning how to cope with it is really the goal. Um, and so the first stage really is to do a good evaluation and figure out what's going on and come up with an idea as to what direction to go in. Individuals who have seen a number of other mental health professionals before, first question I have in my own mind is, um, what's the reason they're coming to see me? Sometimes there can be a conflict of personalities, and I didn't really get along well with that mental health professional, or I'm not responding well. I'm not getting the kind of improvement I hoped I would get. So my initial goal there is to figure out what's missing, um, to start from scratch. If I was an endocrinologist and somebody had a thyroid problem and they'd seen other physicians before, um, but they weren't responding well, they'd still come to me with laboratory results so I could have objective data. But in our field, we don't have that. It's all subjective. And so we have to really clarify by the questions we ask and the interaction we have with the individual, what the symptoms are, what the nature of the problem is, how much of this seems to come from inside biologically, how much of this is due to a life situation, or how much of this is due to a combination of both. And at that point, we then have to make a decision about what direction to go in.
I mean, pretty much anybody who's going to see us is suffering in some way at some level. And uh, the word suffering can be seen as too strong a way of describing some of the reasons why people do come in to see me or to see you. But whether it's feeling sad with grief or even marital problems or just straight anxiety symptoms or existential worries, all kinds of things. To make the step of coming in, making an appointment to see somebody like me and spending the money to do it, you have to assume that that person has some degree of suffering. Now, does the realization that the person's suffering automatically mean that they should take medicine or need medicine? No. So my job is to determine what the suffering is like and how severe it is. And clearly, some people, when they come in, they're really suffering so badly that they do need medicine. And the things that I'll look for are has the person been sleeping at least reasonably well? Do they have an appetite? They have any degree of pleasure in their life? Are they getting out of bed? Are they taking care of basic daily skill, behaviors like taking a shower, things like that? If they're not, then I put that under the really suffering category, and they most likely, I mean, will really, really need to see and be evaluated for medicine. If they're not experiencing that type of suffering, then it's a function of spending a little bit more time, maybe a few sessions to determine levels of motivation, what their resources are in their life. Do they have any help or assistance from people in their life to help them along while they're going through maybe a longer psychotherapeutic process? But as long as they're able to kind of carry on with their day to day lives reasonably well, I will not necessarily jump towards medication. But if they're not really functioning, then certainly they'll get a knock on your door.
I'm glad you raised the concept of suffering because that's a major issue. A lot of people will come in and say, my wife or my husband really can't appreciate the amount of emotional pain I'm in. And that's the problem with our field because, if you have pneumonia, you're going to look terrible, you're going to be coughing, you're going to be weak, and people can really tell that you're suffering. But in our field, oftentimes you look at a person who's got anxiety, difficulties, or depression, and they don't necessarily look terrible. They don't look sick necessarily. And so it's very hard for friends or family members to appreciate the amount of emotional pain and suffering that they go through. A number of years ago, there was an antidepressant that was advertised as treating the pain of depression, that indicating that the amount of emotional pain with depression can be as severe as pain from a bad back or pain from a kidney stone. It's a different kind of pain, but nevertheless, it's persistent. It wears somebody down, and it interferes with functioning. And so, for me, the first step is, besides coming up with a clear-cut diagnosis, is to understand whether or not there are situational factors there. In addition to the fact that they may have a biological depression that's come out of the blue, is there problems with the job? Is there problems in the marriage? Are there issues with school? Because all those things have to be addressed. And then my challenge is to come up with a prioritized system. What's the highest priority issue that has to be addressed first, and then what else has to be worked on? And it's often a mistake just to view the pill as a quick fix, and that's one of the pressures that I find myself experiencing with individuals who come in to see me because they want the quick fix. And so when I say to them, you've had marital discord for 10 years and it needs to be addressed, and it may not be causing a depression, but it certainly make it much worse. You really need to address that. And people are reluctant to take that extra step. They want that quick fix and think it's going to make everything better. But there's no way that a little pink pill is going to help improve a marriage. It may improve a person's emotional state, but it's not going to improve a marriage. So I have to keep my eyes and my ears open to the potential need for more than just medication treatment.
But the reality is, some people do need not a quick fix, but they may need a jump start. And very often I'll see somebody who really has no, I use the metaphor, no wind in their sails. They just have no psychic energy or mental energy or even physical energy. And as a result, they've just kind of come to a halt. And one of the things that I try and see in the beginning is, can my encouragement, can my offering some ideas, some insight, and some hope, can I get a little spark of enthusiasm to get some wind in those sails? And if it doesn't look like talking alone is going to put any wind in those sails, then that's the person that may need, and pretty well sure does need, some medication to get some of that spark going so that they can start to make use of the therapy, or they can get some traction under their feet to make some changes, to make some progress. So it's not, obviously it's not a quick fix, but it may give some boost to their ability to get going and make some changes in their life. But truly, there's no quick fix except for there definitely are some diagnoses where it's heavily loaded. The answer is heavily loaded on medication as opposed to working through problems. But in general, life is complicated enough so that it's hard to imagine really if a person's really suffering that all they need is a pill.
I saw somebody recently who I thought had significant mood instability issues and problems. And after our first session and just talking and trying to clarify some of the issues that this individual had, and the fact that the person was motivated to work on the issues and be introspective, interestingly, there was tremendous improvement just after the initial session, independent really of medication. And that made me realize that one of the things that we're missing in our field is we don't have a biological meter. We don't have any way of assessing how much of this is due to a person's biology, how much of this is actually due to something going on in their brain directly. Whereas we've talked before, other health professionals can get blood tests and x-rays, EKGs, electroencephalograms, et cetera, which gives you a picture of the biology at some level. We now have in the mental health care the functional MRIs. Functional MRI is an MRI that is able to take a look at the active metabolic activity in the brain. So you can see areas that are underactive and areas that are overactive, and so you can actually see the biology. But those machines are huge in terms of the size and huge in terms of cost, and so
Mhm.
they're certainly not something that we can have in our office. Um, so eventually that will be the case. I think eventually we'll have that. But right now, I'm always surprised when people turn out to have less of a biological component and more of a psychological component. You don't know initially. You can't judge a book by its cover. So you have to decide over time, and meeting with them and getting more information and understanding how they're feeling and get a better sense of the life situation and the psychological issues that they're wrestling with, uh, whether or not it's more of a situational psychological issue versus a true underlying biological issue. Certainly, it can be a mixture of both. Um, and then the goal is really to determine which one is which more significant, and we'll talk about that a little bit later in terms of how long to be on medication.
But it may not be that our field is so different because I was just thinking of the person who has high cholesterol. We know that a person manufactures cholesterol, and for some people, no matter how they do with their diets and getting to get control of what they eat, they can't get their cholesterol down. And yet, we know that some people can get their cholesterol down quite a bit if they change their eating behaviors. So it is some degree of some interaction there. And even another example would be high blood pressure, so where, we know that high blood pressure can be genetic and a function of the person's biology, no matter what they do. But for some people, it's some interaction between what they are eating and the amount of salt intake, et cetera. So I think we're different in the kinds of problems that we face, but maybe we've been dealing with this nature nurture issue from way, 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 way back when. And I don't know if we'll ever completely be able to separate nature from nurture, but I guess we can get better at determining, which is the more important, if you will, treatment modality to help the person. But what we have found out is that many patients that we've worked with, it's a mixture, and very often we see dramatic change in people really fairly quickly who we can identify. This is a person who really, really do well with an anti-obsessive medication while we're trying to get them to change the way they think and trying to change their what we would call catastrophic thinking or overthinking. And it's hard to get control of your thinking, but with medicines that can make it a little easier, then a person can get ahead of the curve and really start to make changes. And I think, you and I could probably identify right away at least a half a dozen patients who we've seen in the last few months who have made dramatic progress with that combination. And that's why it's so important to have in mental health more than any other, I think, a team that can evaluate appropriately and treat appropriately.
When people come in and have not seen a mental health professional before, have not seen a psychiatrist before, or even though they've worked with psychotherapists, and the biggest fear is that I'm going to tell them they're sicker or crazy than they think they are, or that this is a permanent condition. And after I do an evaluation and begin to talk about what I think the nature of the problem is, and then talk about the role of medication, people are fearful of that, as we've talked about before, because of the implications. They also fear the fact that here, I'm going to have to be on this medication forever. And I tell people from the get go that, this is not the 10th depressive episode you've had in the past 5 years. So this is a unique situation. It's a lot of life events that have triggered it, and some of this may be your own biology. But I need you to agree to medication to get some relief for a limited period of time. Now the recommendations are for depression. If this is a single episode or a second episode in a number of years, to be on the medication for at least 3 to 6 months after they begin to feel better. And we've learned from the hard way that people who stop sooner can have recurrence of the depression. But letting people know that it's not going to be a lifelong commitment is very helpful. I cannot say that to individuals who have had recurrent depressions over the course of their lives. And sometimes I'll have to say to them that they need to be on a specific mood stabilizer that addresses recurrent depressions as opposed to being on an antidepressants. But the biggest mistake that I see, and we'll be hitting on this as well in the course of this discussion, is the individuals who get placed on an antidepressant by their family doctor, and 10 years later, they're still on it. And that's an issue.
And it may not be even helping.
And definitely it's not helping. And that's also true for anti-anxiety medications too. I mean, one of the eye openers that I saw years ago in a study that came out in the literature was after people have been on an anti-anxiety agent like Xanax or Ativan or Valium or Klonopin for anxiety, after 2 weeks, the true anti-anxiety effects are beginning to diminish and pass. And so it's not necessarily a long-term agent. And so you'll see people who have been on Xanax for 20 years straight, thinking that they needed to still be on it. But the reality was that it probably stopped working years ago. And at this point in time, it's just a placebo.
And, I think people when they get on medication that's helpful and they're starting to feel better, and now they can see, oh, it's been months now and I really feel like I feel better and my life is good again. It's very hard for them to think, well, maybe we can start to look at getting off that medicine. This has become my lifesaver. But on the other hand, we often see people say, I'm feeling better now. I don't think I need it. And then on their own, they go off of it. And as if, I'm all cured and I don't need it anymore. I think in general, most of the people that I see don't want to be on medicine. And that's somewhat a function of most of the people that I see have anxiety problems. People with anxiety tend to want to feel in control and to take a medicine. It's the old thing of I take the pill and put it on the inside. And once it's on the inside, I don't have control over what is going to happen to me. So generally, anxious people don't want to take medicine. But when they start to feel good from it or calm from it, they quickly change their mind about it. But people in general, I think, don't want to be on medicine. But at the same time, in our world today, everything is so quick, and push the send button. And, in 2 seconds, I have a generated a report through AI. So we want quick fixes in general, but it's a mixed bag in terms of whether people want the quick fix with medicine or they don't.
It's an interesting occurrence when people unilaterally decide to stop their medication. One of the issues with that, and I tell people this all the time, is that if you stopped your antidepressant during the critical period of needing to be on it prematurely, there's a risk if you have a recurrence after stopping it that the same medication that helped you to begin with may not work again. and that's a significant risk. And then the opposite occurs. I've had individuals who have been on the antidepressant for a long period of time, long enough to be comfortable with stopping it, who thought they needed to be on it indefinitely and just decided to stop it, and they did fine. And at that point, I'll say, "Well, you tested the system, and let's stay off of it." But the other issue that I think we need to talk about is something that's been in the press recently. Our Department of Health and Human Services, run by Robert F. Kennedy Jr., somebody who I don't necessarily agree with his health related suggestions. There's one thing I do agree with, and that is a number of individuals tend to be on antidepressants longer than they should be. And there may be more people on antidepressants that need to be in the first place. Um, it's easier to write a prescription for an antidepressant sometimes than to do a comprehensive evaluation. I've heard stories from patients who've been to see a mental health professional and filled out a form that's often used to do a checklist for depressive symptoms, and because it's positive, within 5 minutes of seeing that doctor, they get an antidepressant prescription. Um, and as you can imagine, that's not the whole story, but it has led to probably the overprescribing of antidepressants. And so, there's certainly an indication for them, but it's too easy to get out the prescription pad and write the antidepressant. The primary care doctors, internists are under the gun all the time because of the volume of patients they have to treat and how sick people are, and um, how needy a lot of the mental health related problems cause people to become. And oftentimes will view writing a prescription for an antidepressant as the path of least resistance, as opposed to really getting into an in-depth discussion with them about what's wrong and getting into an in-depth discussion about what can we do about it. Um, then there's the other issue of staying on antidepressants indefinitely. Like I indicated earlier, if you've not somebody who's suffered from recurrent depressions over years, there's really no indication to stay on it indefinitely. There is an indication for being on the lookout for any recurrence of the depression so that you can start an antidepressant as soon as possible to cut it off at the pass, so to speak. But more and more, it makes sense to begin to really, really evaluate. If I started this antidepressant 2 years ago during the time of losing a job or losing a marriage or being very, very sick and being under a lot of stress in life, um, do I still need to be on that antidepressant now that my life situation is stabilized and there really aren't the external stresses I had before? So the key issue there is, what's the biology all about? And there are individuals who are predisposed to having depressions, and if the road is flat and there are no potholes, you're not going to have one. But if the road is not flat and there are plenty of potholes and you're bouncing along in the car, you're at risk for having a depressive relapse because of your own biology. So all of this is important to take into account. But for those of you out there who have been on antidepressants for years, it pays to really question whether or not it's still necessary. Well, what was the context in which the depression began to begin with? How frequently have you had recurrences, if any? And then to begin to talk with your psychiatrist about, should I still be on it?
I was pretty happy when that came out a few weeks ago about we really need to reevaluate whether people need to be on antidepressants as much as they are, and also anti-anxiety agents as well. Um, and the reason is that I don't have the data to know. Maybe you do, Dave, as to what percentage of the time people who are put on antidepressants are actually put on by their family physician or primary care physician or general practitioner or et cetera. Because look, the truth is you have spent many years knowing everything there is to know about how to figure out what a person should do in terms of medicine and whether a person needs that medicine. I spent many years from a different perspective trying to figure out who needs to be on medicine. And that's what we do. We kind of know that whole thing inside and out. But the primary care doc doesn't do that. Most of it is just a kind of like a collateral thing. Certainly in many offices now, it's the nurse practitioner who's making decisions about whether or not a person needs to be on an antidepressant. And typically the format is, if a patient says, I've been feeling depressed, out comes the prescription pad. And maybe I'm being a little harsh with this, but I really think it's rather true. So you have so many people. What do? They go to their, as they should, they go to their family doctor to say, I'm feeling bad. And then, okay, that person should be referred to see what does that particular person really need, not just, okay, go off to CVS and get on some Prozac. So I think it really is a serious problem. I think there's a lot of people who are on medicines that don't need to be on it. On the other hand, I know, in my training, way back when, especially in my training in psychoanalysis, it was rare for anybody to say a patient needed to be looked at for medicine. In fact, it was like I still get emails on certain listservs, and the question from people who aren't trained, not medically, does anybody know a good psychiatrist in town? Like, you should know who's a good psychiatrist in town, and you should be working with a good psychiatrist in town. Not, does anybody know one that I can send off this patient to who I've had on the couch for 6 years? So, I don't mean to be too gloomy about this, and I know you don't either, but it kind of is a mess sometimes. So, for patients out there, for people out there who are listening, just listen to this. And that is, if you think you need either psychotherapy or medication or both, if you have questions, the place to go to are the people who know the answers to that. You don't go to Dr. Google, and you don't go to somebody who only knows a little bit about it. That's what I have to say.
Well, but you're right. It is a bit of a mess, and we won't get into it now. But how do you define a good therapist or define a good psychiatrist? I mean, that's really the issue. And um, but the way that I take a look at to the whole medication issue and where to go from there is make believe that uh, biological depression leads to a bright red nose that is so red that you can't ignore it. So if somebody comes into your office and they say, I'm sad and I'm blue and their nose is bright red, that's the biological sign they have a depression. No different than if somebody says, I've got a terrible sore throat and a fever, and you look in their throat and there's a lot of white gunk in there, and you get a strep test and comes positive, then they've got strep throat, they need to be on antibiotics. So for our work, the toughest differential is to determine what is unhappiness and what is biological psychiatric depression. And that's critical. And I tell people this all the time. What you're describing for those last 2 days is unhappiness. Generally speaking, biological depression is day after day after day. It's like a black cloud came over you and won't go away. Or the fog rolled in and the sun didn't burn it off. It's you fell into a dark hole and you can't get out of it. But most of us, when we go through unhappiness, sometimes jump to conclusions that it's the kind of depression that has to be addressed, and that's a mistake. And it requires some education. But so that I tell people this all the time, and especially people who've had horrible depression where they've been non-functional for weeks or months, and they finally come out of it and they're feeling well, and they have a bad day or two. That's when I tell them that that's nothing but a bad day. Like sometimes a cigar is nothing but a good smoke. So that kind of education is critical. So I hope this discussion today has been helpful. I'm Dr. David Gross, psychiatrist.
Dr. Andrew Rosen, psychologist.
And we are Two Shrinks and a Mic.
Bye-bye.
Bye-bye.
The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.